the experience of adverse childhood experiences and trauma. So going back to the study, of the 17,000 members that participated in the ACE study, 1 in 4 were exposed to 2 categories of ACEs, and 1 in 16 was exposed to 4 categories. 22% were sexually abused as children, and 66% of the women experienced abuse, violent or family strife in childhood. And it's important to recognize that adverse childhood experiences are frighteningly common. First of all, the participants who were interviewed in this study were middle-class people with jobs and medical insurance, not likely to have been exposed to street violence, extreme poverty, malnutrition or food insecurity, dislocation, natural catastrophes, or war terror. Of the participants in the study, 72% had attended college, 77% were white, 62% were 50 or older. The groundbreaking element of the ACEs study is that they're us, that the folks that participated in this study were not in identified high-risk demographics, but rather were a demographic that we really do believe to be at lower risk for some traumatic events. This is of epidemic proportions when we look at the widespread experiences in childhood related to trauma, and it indicates the need to address childhood trauma as a major public health issue. And indeed, as we go into looking at the impacts, that really adverse childhood experiences is a shared risk factor or root cause for many of the public health issues and social issues that we're dealing with at the community level today. What we know is the higher the ACE score, the greater the likelihood of severe and persistent emotional problems, health risk behaviors, serious social problems, adult disease and disability, high health and mental health care costs, and poor life expectancies. So we will look at each of these categories through the lens of ACEs and the impact of trauma on health outcomes and health risk behaviors. This information and the slides were from the 2003 presentation by Vincent Folletti and from the Vermitten book, Chapter 6, written in 2007. Highly recommend looking at this presentation or getting this resource for an in-depth look on the impact of childhood trauma. First of all, we're going to take a look at the category of emotional problems. So this is childhood experiences underlying chronic depression. So remember, the statistics that we're looking at now are for adults. So adults with an ACE score of 4 or more were 460% more likely to be suffering from depression. The bar graph that we're looking at now actually may underestimate chronic depression in men, as men tend to be covert rather than overt in disclosing feelings of depression. So here we see the profound impact of childhood trauma on adult mental health. The likelihood of adult suicide attempts increased 30-fold, or 3,000%, with an ACE score of 7 or more. Childhood and adolescent suicide attempts increased 51-fold, or 5,100%, with an ACE score of 7 or more. This is hugely significant. Relationships of this magnitude are very, very rare in epidemiology. And suicidality may be triggered by more than one event, cumulative events, but it is not usually caused by mental illness, drugs, rejection by peer groups, school pressure, failures, etc. Rather, it is an attempt to cope, a way to manage or escape from the overwhelming impact of adverse childhood experiences and or adult trauma. It's easier to get 7 ACEs than you might think. For example, in a family where there is domestic violence, there often exists additional problem or ACE categories, such as substance abuse, drug use, separation or divorce, abandonment, physical abuse, sexual abuse, someone in the correctional system, serious emotional problems such as depression or abuse or neglect. Once an individual experiences one significant ACE, it opens him or her to more, creates fragility, and compromises resiliency. We will look at resiliency as a response to the impact of trauma a little later in the presentation. This is an interesting slide. Compared to a person with 0 ACEs, those with 7 or more ACEs had a 5-fold increase in the risk of reporting hallucinations. Abuse and trauma suffered in the early years of development resulted in a far greater likelihood of pre-psychotic and psychotic symptoms. Childhood sexual abuse and the number of unexplained symptoms. In the medical system, we often don't look for the problem which lies buried in time, concealed by patient shame, secrecy, and sometimes amnesia and frequent clinician discomfort. In the medical setting, we need to dig to find the root causes, for example, of obesity. But without treating the underlying cause, the presenting health issue of substance abuse, obesity, depression, etc., will not likely be successfully addressed. The ACE study really was a way to quantify at the population level the impact of unexplained symptoms across the lifespan and high-risk behaviors. The ACE score and impaired memory of childhood. Amnesia is usually considered a theatrical device of Hollywood movies of the 1940s, but it is in fact alive and well, though unrecognized in everyday medical practice often. In the study, 12% of participants were partially or sometimes totally amnesiac for a period of their lives, typically the few years before other symptoms began. In the ACE study, they found that there was a distinct relationship to the ACE score and impaired memory of childhood, and really understanding this phenomena to be reflective of dissociative responses to emotional trauma. So we'll look now at ACEs and health risk behaviors. A child with 6 or more categories of adverse childhood experiences is 250% more likely to become an adult smoker. Smoking may not be caused by the existence of vending machines or genetic predisposition. A person with 4 categories of adverse childhood experiences is 260% more likely to have chronic obstructive pulmonary disease. I find this to be particularly compelling when I look at the work of prevention. And we've moved towards looking at environmental strategies and community-level risk factors, such as access and availability, low perception of risk, and other community-level risk factors, like laws and enforcement. But really what we're seeing through the ACEs study is that the most compelling risk factor that predicts those high-risk behaviors, including substance use, really are the number of adverse childhood experiences that a person goes through in their early years. When we look at childhood experiences and adult alcoholism, the data is also just as compelling as with tobacco use. There is a 500% increase in adult alcoholism that is directly related to adverse childhood experiences. In fact, 2/3 of all alcoholism can be attributed to adverse childhood experiences. This certainly suggests that alcoholism, contrary to popular belief, may not be simply a disease, but rather a means by which the individual has learned to ease the pain of trauma or to balance his or her nervous system, soothing anxiety. It's always important to address and treat the trauma along with substance use disorder. A male child with an ACE score of 6 has a 4,600% increase in the likelihood that he will become an IV drug user later in life. There is a 78% of drug injection by women can be attributed to ACEs. And keep in mind, relationships of this magnitude are very, very, very rare in the field of epidemiology. The ACE study suggests that the basic cause of substance use disorder is predominantly experience-dependent during childhood and is not substance-dependent. The ACE study also demonstrates that many adult conditions may be experience-dependent during childhood. This really challenges the usual concept of the cause of substance use disorder and other disorders, which has significant implications for medical practice, for prevention efforts, and for treatment programs. Existing problem in practice commonly asks, what's wrong with the person versus what's happened to this person? Traditional practice observes symptoms, develops diagnoses, and treats symptoms instead of underlying causes. To treat symptoms while not treating underlying causes is like attending to smoke instead of the fire. It may be, in fact, the research indicates that when substance abuse is treated concurrently with trauma, relapse rates decrease. The idea of the problem being the solution is certainly in keeping with the fact that opposing forces routinely coexist in biological systems. Understanding that it is hard to give up something that almost always works, particularly at the behest of well-intentioned people who don't have a broad understanding of what has gone on, provides us with a new way of understanding treatment failure in substance use disorders programs, where typically the solution rather than the core problem is being addressed. Indeed, I work in communities all over the country, and really we are starting to see traditional ways of treatment being integrated with innovative approaches to identify and address trauma. And this study really is the foundation upon which a lot of that transition is built. This slide is particularly important. It's really a classic causal relationship. Really, the more adverse childhood experiences, the more health problems an individual is going to experience. It's a dose response, a direct measure of cause and effect. The response in this case is the occurrence of health conditions is caused directly by the size or the dose, in this case, the number of ACEs. The next few slides just illustrate the dose and response. The higher the dose of ACEs, the higher the probability of a negative behavior response. In this one, we're looking at current smokers and the history of adverse childhood experience among residents surveyed in New Mexico. Again, we can see 0 ACEs, 13%, but folks with 4 or more ACEs are 34% likely to be current smokers. This next one is the dose response for people reporting ever having a drug problem. And we can see the number of ACE categories with 0 ACEs versus more than 5 ACEs. The probability of problems resulting from multiple adverse childhood experiences is really at the heart of the work that we do related to the disease of substance use disorder. As we know, that substance use disorders and addiction really begin, for the most part, in adolescence. And research has demonstrated a strong graded relationship between adverse childhood experiences and initiation of substance use. Here you see adverse childhood experiences grouped from 0 to 4 or more. As the number of adverse childhood experiences increases, the initiation of alcohol use before the age of 14 also increases. 4% of participants with no adverse childhood experiences engaged in alcohol use compared to 16.9% for those who experienced 4 or more ACEs. A similar relationship is observed when looking at drinking initiation between the ages of 14 and 17, but the result is not as strong. For communities, states, tribes, and jurisdictions focusing on underage drinking, these results should be alarming and suggest the importance of addressing ACEs as one component of preventing underage drinking. According to the study authors, responses to underage drinking will not be effective unless they help youth recognize and cope with stressors of abuse, domestic violence, and other adverse experiences. Given the negative impact of early initiation of alcohol use on neurodevelopment and the evidence that adverse childhood events also impact neurodevelopment, these findings are concerning. As with alcohol use, adverse childhood experiences increase the likelihood of early smoking initiation, which is smoking before the age of 18, with 21% of those with 4 or more ACEs reporting early initiation of smoking compared to only 5.5% with no ACEs. Moreover, ACEs lead to continued smoking, heavy smoking, and while not shown here, the risk of chronic obstructive pulmonary disease, or COPD. Another analysis looked at initiation of illicit drug use before the age of 14 and between the ages of 14 and 18. Again, the graded relationship is observed with more ACEs associated with greater likelihood of illicit drug use initiation. Again, when I look at the ACEs information, and I look at it through my lens of a preventionist who works at the community level to address community level risk factors, it's impossible not to recognize that we'll never make population level outcomes related to prevention of drug and alcohol use if we're not taking a systems approach at looking at adverse childhood experiences and building resiliency and helping people develop capabilities so that they do not engage in high-risk behaviors as a coping mechanism. We're also going to look now at the impact of adverse childhood experiences on serious social problems. So childhood experiences underlie rape. So this can be the repetition of the original trauma. Victims of cumulative early childhood traumas that have never been addressed are much more highly vulnerable than others to being re-victimized by rape or by domestic violence. Women with an ACE score of 4 or more are 500% more likely to become victims of domestic violence, and they are almost 900% more likely to become victims of rape. ACE score and the risk of being a victim of domestic violence is also compelling information. The more adverse experiences as a child, the higher the risk of becoming a victim of domestic violence. This is not exclusively for women, but is the case for both women and men. When it comes to perpetuating domestic violence, the risk is also increased. Just as the risk of becoming a victim of domestic violence rises, so does the risk of becoming a perpetuator of domestic violence. Again, this is true for both men and women. We also see the impact of adverse childhood experiences on the likelihood of having more than 50 sexual partners, and also increased risk for unwanted pregnancies, socially transmitted diseases, and HIV and AIDS. Again, the ACE score also correlates to unintended pregnancy or elective abortion. Here we see the higher ACE score in red, and that's for the unintended pregnancies with the number of ACEs, and the elective abortions in yellow. Sexual abuse of male children and their likelihood of impregnating a teenage girl also increases with the number of adverse childhood experiences. Boys who were sexually abused are more likely to impregnate a teenage girl, and the earlier the age when the boy was sexually abused, the greater the likelihood that he will impregnate a teenage girl. Again, these data are compelling. The ACE study really allowed us to draw direct correlations between childhood trauma and some of these behaviors that are at the heart of social issues that we're trying to address. We also see that the frequency of being pushed, grabbed, slapped, shoved, or had something thrown at oneself or one's mother as a girl, and the likelihood of ever having a teen pregnancy is correlated. This is about the relationship of violence to either self or to mom and getting pregnant. The more frequently girls are pushed, grabbed, slapped, shoved, or had something thrown at them or at their mothers, the greater the likelihood the girls will have a teen pregnancy. Again, engaging in those high-risk behaviors become a coping mechanism in response to the trauma. The ACE score also has an impact on the economy. The higher the ACE score, the more difficult it is for an individual to make a living. Here is a graded relationship between ACE scores, absenteeism, serious financial problems, and job problems. We will look now at the impact of adverse childhood experiences on adult disease and disability. Adult disease and disability are often an outcome of adverse childhood experiences. One example of note is that in a study of Native American women in a primary care setting, 77% reported childhood physical or sexual abuse and severe neglect. There is a significant graded relationship between adverse childhood experiences and the rate of sexually transmitted diseases. Some sexually transmitted diseases obviously can lead to infertility. Included in this statistic are chlamydia, gonorrhea, genital herpes, HPV, pelvic inflammatory disease, syphilis, HIV and AIDS, and other sexually transmitted diseases. We also see that there is a correlation between the ACE score and the prevalence of liver disease, including hepatitis and jaundice. Really, looking at these statistics, it's overwhelming to see really how impacted the entire field of public health is by childhood trauma. ACEs increase the likelihood of heart disease. For instance, the ACE study found that there's a strong relationship of ACE score to coronary disease, correcting for all the conventional risk factors like smoking, cholesterol, etc. This illustrates that adverse childhood experiences are related to adult disease by two basic etiologic mechanisms. First, that conventional risk factors are attempts at self-help through use of agents like nicotine with its documented multiple psychoactive benefits, in addition to its cardiovascular risks, and the effects of chronic stress as medicated through the mechanisms of pro-inflammatory cytokines and other stress responses on the developing brain and body systems, dysregulation of the stress response, and pathopsychological mechanisms yet to be discovered. There's really a high health and mental health care costs related to adverse childhood experiences. And this cost is reflected in the following graphs to come, showing the higher the individual's ACE score, the higher the utilization of costly prescription drugs. The study really points to pharmacy data and looking at prescription drug use through 50 to 60 years after the fact. Prescription costs are an increasingly significant portion of rapidly rising national health care expenditures in the United States. And by successfully addressing adverse childhood experiences, those costs could be significantly decreased. Here we see the ACE score and the rates of antidepressant medications approximately 50 years after the adverse childhood experiences took place. Here we see the ACE score and the rates of antipsychotic prescriptions 50 years after the adverse childhood experiences take place. Again, the costs across the lifespan are profound. We also know that adverse childhood experiences is directly linked to mortality, to poor life expectancy. The bars represent the percentage of people of different ages. So pink is 65, blue are ages 50 to 64, green represents ages 35 through 49, and the yellow bars represent ages 19 to 34, coming in for comprehensive medical evaluations. Age distribution for the ACE score 0 individuals is what one would expect. Old people are more likely to come into healthcare for medical evaluations than are young people. Intermediate age quantiles have the expected relative proportionality. However, at ACE score 2, it's reversed. And at ACE score 4, the age group of 65 has almost disappeared, while all other age groups coming in for comprehensive evaluations have dwindled significantly. This is one indicator, and the study itself anticipates that when there is prospective analysis of death rates completed, it will find an increasing death rate as the ACE score increases. Again, this is a young study, but it really has strong indications that that will be validated in future studies. So now that we have taken a look at the impact of ACEs on health and behavioral outcomes over the lifespan, let's refer one more time to the study. Now, again, I'm watching the chat box, and if anyone has any comments or would like to make any observations related to the statistics that we just looked at, I'm going to just pause for a moment and invite people to make any comments or observations or responses to what we just covered in the chat box. So I'm just going to hold on for just a moment and give folks an opportunity to share any thoughts. Again, it's just me that can see the chat box. Okay, we have no comments in the chat box, so I will continue moving on into the next section.
Hold on. This is Leanne. Dorothy, I do see some comments and a couple of questions in the chat panel. Would you like for me to read those to you?
I would absolutely love that. Yes, thank you.
Okay. Early in the presentation, one of our attendees did bring up the topic of bullying and said that it doesn't look like bullying, or she wrote, bullying is not listed. Again, this was earlier, I think, in the presentation. Bullying is not listed, so is this one specific focus that was not included in the study, or maybe it falls under emotional abuse?
Bullying, thank you, Leanne, for monitoring the chat box, and thank you to the participant for that question. No, you know, the interesting thing about the ACE study is it was very specific in how it identified adverse childhood experiences. And as I referred to it back earlier in the presentation, it's not an exhaustive list. So things like bullying would not have been adequately gauged in that study because the 17,000 participants would not have known to respond to questions of bullying the way the study was framed. What that tells me, however, is that the impact of adverse childhood experiences is even much more profound than we know because of the limitations of the study. Indeed, we're seeing the impact of bullying on high-risk behaviors and morbidity and mortality profoundly impacted. And so as the ACE study really was the tipping off or the jumping off point that really drew a quantitative correlation between high-risk behaviors, negative health outcomes, and trauma. And there are more and more studies that are being conducted now as the result of this clinical study that include things in a broader definition of trauma, such as bullying. Thank you. That was a great comment or question.
Great. Okay. So moving on. We do have a couple of other questions. I'm just kind of looking through them. They're coming in pretty quickly in the chat panel.
I'm seeing them now, too, Leanne, too.
I would remind everyone that we will be making a PDF version of the PowerPoint available 5 days after the presentation, and that'll be available on our website. We'll also be emailing that. A question did come in as to what ethnic groups were included, or do we know what ethnic groups were included in the ACE study?
Well, that's a really good question, and we do know what ethnic groups were included in the ACE study, and it was really predominantly white. The 77% were college educated, 77% were white, and 62% were 50 and older. And what is really compelling about this, remember, this was the first study of its kind. So those demographics would be traditionally considered at lower risk for adverse childhood experiences. So when we extrapolate that across demographics that have historical trauma, issues related to poverty, homelessness, institutional racism, additional risk factors, we know that there's going to be even higher rates of adverse childhood experiences, not only within the family, but at the community level. Really what this shows is that these statistics, as compelling as they are really not even representative of the true impact of adverse childhood experiences across multiple demographics.
Another question, are there ACE assessments or questionnaires currently available that can be used by clinicians?
There are. That's a good question. And I didn't actually include any instruments in this presentation, again, because it's really an introduction. I would use some of the links that are included in here. The CDC, actually that's the slide that's up, is a great resource to use. I can tell you that I serve as the chair of the policy committee on the Board of Education in my community, and we have, as a school system, gone towards trauma-informed schools in response to really understanding the scope of adverse childhood experiences. And there are several community-level instruments that can be applied in multiple contexts, in clinical settings as well as school and community-based settings. Some of the downsides, though, of the administration of an ACE instrument is, for example, some schools are reluctant to administer an ACE instrument because they don't have adequate resources to funnel people into when they discover folks that are at higher risk because they're experiencing multiple ACEs. But there are a number of links that you can find that are embedded in this presentation.
Okay, great. A couple of other questions related to this study. What is the beginning date that the ACE study began? Is it an ongoing study? And if not, when did it end?
This was a study that took place over a 4-year period, and it began in the early 2000s, and it is not continuing. This was the first study of its kind. However, as I mentioned just a few minutes ago, it really was the tipping off point. This was a really groundbreaking study, and there are a number of studies now that are underway that are expanding the work that was begun by this particular study. So again, I would recommend as a starting point going to the CDC, because that is obviously the most reputable web link. SAMHSA, the Substance Abuse and Mental Health Services Administration, also has a lot of information on ACEs and how to inform our practice on their website as well. That will be included a little bit later on in the presentation.
Thank you, Dorothy. We have another participant who would like for you to repeat something that you had said a bit ago. She writes, you had mentioned teaching resiliency, and I did not get the second part of your statement. Can you repeat that?
Yes, one of the, and we will get into that in a little bit, one of the primary responses to combating the impact of adverse childhood experiences is on building resiliency as a coping mechanism. And we will go into that in a little bit more detail in just a few moments. Leanne, I am going to suggest, as you had mentioned yesterday when we were speaking, that we might want to take a 5-minute break now since we're here at the hour mark, and then that would give us an opportunity to go through the comments and make sure that we can respond to them at the end of the break.
Okay, that would be fine. So we'll go ahead and take a 5-minute break, everyone. I have 11:03 on my clock, so we're going to reconvene at 11:08. Thank you. And Dorothy, I was just going to let you know, I know we're still live, that we do have a few comments and questions that have come into the Q&A panel as well. You might be interested in looking at that. And I will pick up 1 or 2 of those if you don't see them.
Great, thank you.
Dorothy, we're going to get started in about another minute. Do you need anything else from me before we do?
No, I'm ready whenever you are. And I think that we will clear up any of the questions that have been asked at this point before we move on to the last part of the presentation.
Now, would you like for me to continue reading through them, or are you able to look at them yourself? What's your preference?
I have one that I saw from the comment box, but I'll get you after. I'll respond to that one first, and then I would love it if you could read the questions out of the Q&A.
Okay, I'll see what's come in the meantime. And I think it's 11:08, so welcome back, everyone. And if Dorothy, if you're ready, we'll go ahead and resume.
We are, and I want to kick off our reconvening with a really good question that I read over our short break. And the question is, we all experience trauma. What determines how trauma affects some people but not others? And let me say, first of all, that's the million-dollar question. And what the ACE study really did do was start us on a whole new field of exploration to really look at the impact and to identify the types of trauma and how they impact us across the lifespan. We don't know with as much study what those factors are that create resiliency. However, we do know that increasing coping mechanisms and increasing resiliency are two really important concepts when we're looking at how people can navigate through adverse childhood experiences and go on to live happy, healthy, functioning lives from the outside perspective. And it's interesting to note, as we talk about this, we're not talking about resiliency in terms of just building individual resiliency, but we're talking about this at a population level, how we can actually align our systems and processes so that we create resilient organizations and policies that are going to support population-level change. And that's different than creating one program after the next to create resilient individuals. And that's really where the field is moving, is supporting organizations and systems to adopt policies related to developing resiliency, while also working with individuals in counseling and treatment and other programs to build individual resiliency.
Thank you, Dorothy. And I think we've got one other question in the Q&A, and it's sort of related to what you were talking about just now in terms of resiliency, or I think it may be connected. This comes from a group of individuals who are watching the webinar together, and they're saying that they're all in their late 60s. They all have higher ACE scores, but they've all been involved with some support assistance, and they're wondering if you think that these positive support experiences, may have a mitigating effect on some of the prior damage, or that it may offer some medical assistance or be cardioprotective, and that's their language.
The answer to that is absolutely yes. In fact, what we're seeing is some of the most powerful agents of change in combating the impact of adverse childhood experiences are the people who have experienced multiple ACEs and who have really turned what I call a vicious cycle into a virtuous cycle, where they have developed resiliency and coping mechanisms, and then they become the front lines to really help to mitigate the impact of ACEs on future generations or on others, and really stop that vicious cycle from continuing. So absolutely, persons who have experienced multiple ACEs, who have received appropriate supports, have developed coping mechanisms, and that resiliency are really the key to how we change the tide of the impact of ACE on health outcomes. Absolutely.
Wonderful, Dorothy. And I think we're ready to resume our presentation if you are.
I sure am. Great questions, everyone. Again, my preferred way of instructing is face-to-face, so I absolutely appreciate the questions and comments. It just makes our session that much more rich and full. So going back to the ACE categories now, they're interrelated, and we know that. So earlier in the presentation, we said that if someone has one ACE, so for example, child physical abuse, there's a higher probability that there's going to be multiple ACEs involved, such as physical neglect or emotional neglect. And I also want to point out, again, like one of the comments that was earlier made was that these are really limited categories of trauma. It doesn't include, for example, experiential trauma. It doesn't, just to share my own story, I lived in a house with multiple adverse childhood experiences, but one of the most compelling traumatic events in my life was that when I was 16 years old, I went to an underage drinking party. I had already started to engage in high-risk behaviors as a coping mechanism for substance abuse and neglect within my home. And at the underage drinking party, my best friend was killed in front of me by a motor vehicle when we were fleeing the party. And that was probably the event that put me in the years of a tailspin until I could really figure out how to build resiliency and to develop coping skills that weren't negative. And so I share that story to say, when we look at these categories of trauma, they're so limited, which tells us if we saw such compelling research come out of such limited identification of trauma, when we expand that definition, how much more impacted our the issues that we're working on really are. And we know that they're interrelated. So we know that there's many indicators of family dysfunction, so mentally ill, depressed, or suicide persons in the home, family members with substance use, parental discord, which can be indicated by divorce, separation, or abandonment, or witnessing domestic violence against the mother. That was a very compelling one as well, or incarceration of any family member. Now, we have long known these to be evidence-based risk factors for high-risk behaviors and negative health outcomes. But not until the ACE study did we really see the full impact of that specific risk factor over other risk factors that exist at the community, family, or school level. So we've done a whole lot of looking at what the ACE study showed. And according to Dr. Robert Anda, what is predictable is preventable. So the question then becomes, how do we move from prediction to prevention? And remember, the ACEs work does not mean that there's an absolute correlation between, or an absolute, that once a person has multiple ACEs, that they will engage a high-risk behavior in high-risk behaviors. It means it increases the probability. And what we really need to do is we really need to sort of help use what we've discovered in the ACE study to really help us understand the drivers of population health and well-being. So again, the ACE study is looking at individual risk and individual trauma, but it extrapolates, as the data showed us, into population health. And that's where this study really becomes groundbreaking. You know, we've been talking a little bit about neuroscience research, which is the study of individuals. But really, now we're going to switch gears a little bit and talk about the population as a whole. It can be challenging to think about how the whole population is affected by an individual disease agent. But when we, in our field, are interested in transformational change, really we need to find high-leverage solutions to problems. And so we need to think about what would produce population-level improvements. So really, that's turning to the field of epidemiology. The study's theory that we experience today was that adverse childhood experiences lead to social, emotional, cognitive impairment, which leads to adoption of risk behaviors, which leads to disease and early death. The ACE study was designed to determine whether or not adverse childhood experience could be an underlying cause of a portion of diseases experienced in the population. Now, it's important to note that prior to the study that was conducted by Dr. Anda, he had been a leader in the field of reducing heart disease. And his work through the 80s and into the 90s was about identifying risk and protective factors that predicted heart disease. And he worked to reduce the risk and increase the protective factors. And indeed, we adopted much of that theoretical framework working in prevention of substance use disorders. You know, and we all recognize the risk and protective model. It's been the prevailing model for prevention in fields for most of my life anyway. But Dr. Anda knew that risk for heart disease, as well as risk for many mental, physical, and behavioral disorders, is not randomly distributed, and therefore could not be the underlying cause of health problems he was dedicated to resolving. So prior to the ACE study, Dr. Anda won many prestigious awards for his work leading primary, secondary, and tertiary disease reduction strategies using a risk and protective factor approach. But he left that behind in order to find and really do a deep dive into the underlying causes of ill health. Really, this is pioneering work that uncovered evidence of the most powerful determinant of public health. It also challenged long-held beliefs that pathways to disease and theories about how best to interrupt them. For example, we always identified smoking as a risk factor for heart disease, and indeed it is. But this study illuminated the fact that going even further upstream, one of the greatest risk factors for smoking is actually adverse childhood experiences. And so if we can mitigate the impact of adverse childhood experiences, we really are getting to primary prevention of a plethora of high-risk behaviors that lead to poor health outcomes and early morbidity and mortality. And really, this is the heart of what the impact of ACE is. That adverse childhood experiences, that trauma, limits our ability and our capabilities. The impact of trauma is centered upon how a person's capabilities develop. Now, one of the other comments that I read during the break was about in treatment, a treatment provider shared that many of their patients, most of their patients, really don't have coping skills. And that goes back to the adverse childhood experience theory. That fundamentally important concept is that adverse childhood experiences impair one's capabilities, their coping mechanisms, and especially when we look at this and how it then impacts trauma in future generations. Because if I am impacted and I don't have the right capabilities or coping skills as an adult, and then I become a parent, then I, in turn, transform my adverse childhood experiences into second-generational adverse childhood experiences. And at the heart of capability, what we know is attachment and belonging. That trauma impacts a person's capability to develop attachment and belonging. We saw this very, very clearly when we saw the correlation between multiple ACEs and, for example, multiple sexual partners. That we see that some of the most impactful behaviors are real strong outcomes of the fact that people who experience trauma don't develop healthy mechanisms for attachment or belonging. Think about children who are food insecure, who are experiencing abandonment or neglect. As a mom, when I think of this, I think of the impact of adverse childhood experiences across the lifespan. And there was a child in second grade that was with my daughter when she was in second grade. And this child was very insecure when it came to her family situation. Both of her parents had active opioid use disorders. And so at the very beginning of the year, I noticed this child was looking extremely stressed every day after school. Now, most children are excited to see their parents or their caregivers picking them up and excited to share about their day. And this little girl looked so stressed at the end of every day. There was almost a look of panic on her face. And what I recognized or realized was she didn't know who was going to pick her up or if anyone was going to pick her up. And so I started every day after school seeking her out, and I'd hold her hand and I'd say, who is going to pick you up today? What car do you think it's going to be? And I tried to alleviate that stress. And certainly she spent many, many, many nights at my house. But what I think about is I think about her disconnection from feeling belonged or from a sense of attachment and what that impact is going to be across the lifespan and how prevalent that is. Clearly, when children with ACEs become adults, the way that they function and the health behaviors that are developed throughout adulthood impacts future generations. This is a really fundamental concept, is that it perpetuates itself. The other piece that we need to also be cognizant of is community, culture, and spirituality. We don't exist just within families. We don't exist just within family units, but we also live in the context of our own community and culture and spirituality or lack thereof. Of course, looking at a broader view, we look at a person's capability and that impact on their feelings of attachment and belonging. And beyond that, the fact that external factors such as community, culture, and spirituality can be a mitigating factor, serving as a means to help the issue or to make the issue worse. External factors impact how people with trauma function as adults. So we see community or cultural level factors that exacerbate childhood trauma, such as institutional or systemic racism, poverty, historical trauma. Or it can also serve to be a protective factors, looking at extended family potentially, or protective cultural practices, or religious practices that create a sense of belonging or help create that sense of attachment to community and to family. So community, culture, and spirituality is a critically important element. So moving towards solutions, and really what we're looking at as we're really trying to expand this field and figure out how we can extrapolate individual neuroscience data into population-level strategies. And really what we're trying to do is create a virtuous cycle where there is a vicious one. So let's look at the way we can identify adverse childhood experiences as a strategy to proactively identify solutions. First of all, looking at the data, we have a theoretical frame so that we know that if we identify moderate ACE effects among parenting adults, if we build on their strengths to improve functioning, coping, and resiliency, we can actually work to prevent adverse childhood experience accumulation in the next generation. So if we work to intervene with people who have multiple ACEs, we may not completely mitigate the impact of ACEs, but if we reduce it, in turn, we then will reduce the number of adverse childhood experiences of the next generation. And so we know that we're reducing risk when we reduce the number of ACEs. Ultimately, we would like to get to a point of 0 ACEs, but if that's not possible, we also know that it's really a harm reduction strategy to provide skills development and coping mechanisms to a parent, for example, who's had 8 ACEs, so that they can reduce the level of risk, and they're really only transforming or transferring 2 or 3 adverse childhood experiences to the next generation. In turn, if we're working with that child to reduce or mitigate those 2 or 3 adverse childhood experiences, then as we move into the next generation, we may actually end up seeing a place where that vicious cycle of intergenerational trauma, abuse, and high-risk behaviors and chronic disease is mitigated to the point where we see really positive population outcomes. And really, so the concept here is the ACE transmission risk. So we know that adverse childhood experiences is really one bucket, and that's where the study was focused. But there's also, as I mentioned, historical trauma, adverse peer or school experience, which goes back to expanding that definition to include bullying, and adverse adult experiences. Remember, this study did look at the impact of adult trauma. It did look at the impact of adverse childhood experiences on the higher probability of adult trauma. But adult trauma also has an exacerbating effect. But what we look at is multiple mental, physical, relational, and or productivity problems, which then increase the risk of transmission of adverse childhood experiences onto the next generation. So we have, for the most part today, been looking at how trauma in childhood impacts adults. But there are many more immediate negative impacts of childhood trauma, which, as we just explored, is often transmitted by adults who have multiple adverse childhood experiences. Again, the impact of the vicious cycle. I mentioned a little bit ago that I'm on the Board of Education in my community, and our public health system, or excuse me, our public school system has really moved towards recognizing this information and adopting a trauma-informed approach, while also interfacing with prevention and treatment providers and healthcare providers within our community to essentially expand and create a net where parents and adults who have experienced adverse childhood experiences are receiving programs and services to mitigate the impact of those adverse childhood experiences and to reduce the number of ACEs that are transmitted to children, while at the same time our schools are taking concerted universal approaches in reducing the experiences of ACEs. This, as a practitioner who's been working in the field of substance use disorders treatment and intervention and prevention for over 25 years, really feels like we're starting to be on the cusp of fundamental change by looking at how we can align our systems and processes and become trauma-informed. But we see that in elementary school, the greatest single predictor for health, attendance, and behavior is the number of adverse childhood experiences. Adverse childhood experiences are the second strongest predictor for academic failure. So among youth, 33% of court-involved youth reoffended in 2 years, and that's with 4 ACEs or more. 51% of children with 4 ACEs or more are in special education versus 33% who have 0 to 1 ACE. And 74% of youth who have ACEs of 4 or higher have a GPA of 2% or 2.0 versus 58% of folks with 0 to 1 ACE. 64% of youth with adverse childhood experiences have 4 or more suspensions, and 85% of children who experience 4 or more ACEs are suspended by 2nd grade. Again, these statistics are nothing short of horrifying. I know in my school district that we don't often suspend 2nd graders, and certainly as systems and organizations become trauma-informed, suspending a child with 4 or more ACEs is really showing to be counterproductive. So the adult adversity that happens because of adverse childhood experience, such as incarceration, victims of violence, substance abuse problems, mental health, all of those other problems that we identified earlier on, are conditions that are commonly present for adults who have multiple ACEs. And this is what leads to that intergenerational vicious cycle. So we know that parents with ACEs are going to experience many of these conditions, and parents with 5 or more ACEs are 14 times more likely to have 2 or more conditions that make ACEs for kids. Again, the key to this is how do we break that vicious cycle. So ACE informs change. So for example, we know that there are transitions from preschool to kindergarten, and that the early identification of adverse childhood experiences birth to 3, we can have compelling outcomes if we identify those adverse childhood experiences prior to starting kindergarten. So many communities that I work with are actually trying to implement ACE screens in primary care settings, in Head Start, in community-based and service organizations. So in that birth to 3 range, they can identify ACEs as early as possible so that they can be subject to effective interventions, which will really set them up for success by the time they're in kindergarten and early elementary school. We also know that we need better treatment for adjudicated youth. So we know that we need to move from a punitive response to high-risk behaviors for which kids are in the system to looking at how we provide support for and develop resiliency in response to the fact that children who are in the system have most likely experienced multiple adverse childhood experiences. And we also know that ACEs are common, so we need to work in universal systems. And to me, that's the most important bullet on this slide. ACEs are individual risk factors, but the ACE study revealed just how prevalent ACEs are. So we need to look beyond individual response strategies to look at the implementation of universal strategies that impact systems. So at the heart of this, I really use the terms, 2 terms, coping and capability, and then beyond that, resiliency. And they really are 3 sides of the same triangle. It really is helping individuals self-regulate so that they develop healthy coping mechanisms in response to the trauma that they've experienced, not only in childhood, but as we discovered, also any kind of experiential trauma that could happen outside of childhood in adulthood. And really, the central concept here is at a systems level, we need to, and we're starting to see schools and organizations adopting policies to change the way they function, becoming more trauma-informed, and implementing practices such as mindfulness. We see many schools now, for example, taking policy approaches to implementing mindfulness as a strategy to reduce the impact of adverse childhood experiences, of organizations and agencies encouraging and setting policies that encourage exercise and practicing connection and creating environments that are going to be conducive to connecting and creating spaces for people to be mindful and to reflect, which all are really healthy coping mechanisms to the fact that so many people at the population level are dealing with multiple trauma. And at the heart of this is really resiliency. Resiliency is the ability to meet challenges and survive and do well despite adversity. And sometimes we see children, for example, who have stories of growing up in poverty or homeless, and they end up going to Harvard, and they're almost put on a pedestal like the exception rather than the rule, coming from those places of multiple trauma and adverse experiences. But there's a science behind it. Really, Those youth are examples of youth who have developed, usually on their own, resiliency. But there's a lot of science behind resiliency. And so we need to, as an organization and system and community, look at how we can coordinate and expand resiliency. Now, just like risk factors, so if you're going onto the Substance Abuse and Mental Health Services Administration website, you'll see a slide almost identical to this that says that risk factors occur at all levels: individual, family, friends, school, community, and global. Well, resiliency exists at all of those levels as well. And really, resilience is a term that comes from the physics of materials. In that context, it means the ability to return to original form after having been bent or compressed. For example, bamboo is considered to be resilient because the plant can be bent to the ground, but it will spring back, grow well, and be essentially unchanged. You see that in Florida with palm trees in a hurricane. But human beings aren't just materials that can spring back to original form or function after significant trauma, loss, or attack. We actually are changed by experience through a complex process of adaptation. Adversity and trauma brings about a new form and function that actually allows us to fit in a new environment. And so when we look back earlier, things like amnesia is an example of those coping mechanisms that are in response to trauma. In psychology, resilience has been conceptualized in a few different ways, but all of these contain the themes of adversity and doing well. Researchers have defined doing well and adversity, so learning about resilience requires paying attention to several key concepts. What measures of doing well are used to gain insight about resilience? How do we define doing well? How is adversity defined? How is adversity related to the developmental tasks of individuals at various ages and developmental stages? And how are adversity and its converse, doing well, related to the history and the culture of a community? So across all of those domains, resiliency is more than the absence of trauma. It's not just recovery immediately after a crisis. Resiliency is almost like surfing. It requires continuous balance and grace, the ability to spontaneously respond to the demands of unforeseeable dynamics of life, eagerness to learn, and to use new skills in maintenance of one's physical and emotional health, and one's spirit for living life with joy. And indeed, for those of us who work in treatment with clients, isn't that what we're helping and supporting our clients to get to? Is those healthy ways of coping with the everyday stresses of life, as opposed to using those unhealthy ways of coping, using the substance. We're really looking at how we can identify risk factors based upon adverse childhood experience and overlaying resiliency across all levels of individual services, of public health, and of our general community, which will lead to the powerful potential to look across all of our systems, organizations, and individuals to transform our practice at every level to be trauma-informed. You know, I do a lot of work on collective impact, and one of the concepts that we talk about with collective impact is all of the organizations and agencies have a role to play in solving the problem. But while we have a role to play, none of us is completely responsible for. So, for example, we may be a treatment provider and we're working to develop healthy coping skills for folks that are in our treatment program so that they can deal with the everyday stresses of life without turning to their substance of choice. But the idea of collective impact is one treatment provider has a role to play, but they also need the support of agencies, systems, and communities so that we're all working on promoting coping skills so that when the person leaves, the client leaves the treatment provider's office, that they don't also lose that support to develop healthy resilience coping skills, but that they're found in all of the systems and within the community that they live, which creates that collective impact or environmental change, which is why it's so exciting that schools are moving towards being trauma-informed, that organizations and agencies are looking at the impact of adverse childhood experiences on how they can change the way they do business. Again, it's that collective impact, that individually none of us have the responsibility for solving the problem. Individually, each of us has a role to play, but it's only when we all step into that role and work collectively that we're going to actually be able to make population-level changes. This is an interesting depiction that you just really measured here on what events that we can see that happen to a person. But really what we need to do is increase the probability of lasting change when we actually look at patterns and structures, mental models, values and principles that are often based upon a person's childhood experiences. The way we view the world, what we value, is often runs very deep. And it's often impacted by how we were raised as children, of what we lived with, how we were parented. And really, we need to get to that level of analysis so that we're not just looking at the risk that we can see on the surface, but we're really going deep so that we can address the trauma that underlies what we can see on the surface. So ACEs are a good example of the type of complex issues that the prevention workforce often faces. And I can see from the comments in the chat box that this is really a reinforcement of what many of you, especially treatment providers, see every day in your office. The negative effects of ACEs are felt throughout the nation and can affect people of all backgrounds. And I also want to highlight, just as that question emphasized today, the ACE study was 77% white and 72% had attended college. So we know that is the lower, traditionally considered lower risk demographic. So imagine the impact of adverse childhood experiences when we look at other demographics that have many more risk factors. So successfully addressing the impact of adverse childhood experiences requires assessing prevention needs and gathering data, which is really guided by the strategic prevention framework. Prevention efforts aligned with widespread occurrences of adverse childhood experiences and building relationships with community partners through strong collaboration. And that's really what SAMHSA has required coalitions to do in looking at prevention by using a coalition model which implements the strategic prevention framework, which really is collective impact. And so the Strategic Prevention Framework, or SPIF, is used to assess prevention needs and gather data. Now again, any of you who are on the line today that work in prevention or work on any projects that are funded by the Substance Abuse and Mental Health Services Administration on the prevention side, or at the Drug-Free Community Program, you're required to use the community-based SPIF, Strategic Prevention Framework, to guide your work. SPIF requires 7 steps of completion, and I really use those arrows because it all begins at the very top of the cycle, which is assessment, which is using data to guide the work to develop and implement and evaluate plans, and then to use that data again to measure your success. When we're looking at how we can first of all get a lay of the land and moving into incorporating adverse childhood experience data into understanding what's happening in our communities, we need to look to the Strategic Prevention Framework to identify what to assess. Traditionally, we've been looking at the nature and extent of substance use problems and related behaviors, and also risk and protective factors that influence the problems and behaviors. Again, we look at those evidence-based risk factors across the domains. Adverse childhood experiences is a deeper way of looking at those risk and protective factors. And again, working with agencies and systems within our community and our organization so that we can have broad implementation of an instrument to gauge ACEs is going to give us a much deeper view of what's happening related to substance abuse and behaviors in our community. It's going to give us the whys. And the strategic prevention framework also challenges us to identify and assess the existing resources and readiness of community to address its problems. So how does this apply to ACEs? Well, part of the work is to identify and name and frame the impact of ACEs in our community so that we can build and raise awareness of other resources and agencies in our community so that we can all get on board and recognize that to truly address some of these health disparities and negative health outcomes, we need to be trauma-informed and as systems take a trauma-informed approach. Integrating access ACEs into substance abuse efforts. Now, this came directly from the SAMHSA website, and so you will be provided with a PDF of these slides, but I wanted to also highlight that what SAMHSA says is because ACEs are commonly and strongly related to a variety of substance use and disorders, that preventing ACEs and engaging in early identification is critical for practitioners. So collecting state and county level ACE data through instruments like the Behavioral Risk Factor Surveillance System, and that's going to give you broader community level data, but you would also want to use instruments at the organizational level as well. And that data can help you increase awareness of ACEs among your key stakeholders. And including ACEs among primary risk and protective factors when looking at prevention planning efforts. And selecting and implementing programs and strategies that are going to address ACEs. Again, so many times we address the presenting problem, but if we don't look beyond the presenting problem to what is the cause of that presenting problem, we're never actually going to see significant and sustained positive outcomes. So what can we do? First of all, this was just an introduction into the concept of adverse childhood experiences. And clearly, many of you know this because you experience and see it in your work. And again, most of us have been working in this field. We know that trauma is at the root of many of the issues that we see. But this study validated it. This study gave us hard data to actually show a relationship between trauma and the behaviors that we're working to address. There's so much research out here now. This ACEs study really did serve as a jumping off point, and there's a lot more trauma-informed services and supports that are in place now or being developed. Again, I would highly recommend utilizing some of the links that are embedded within this presentation to do a deeper dive into what might be appropriate supports for your agency and organizational. Shifting to dual generation strategies. So going back to changing that vicious cycle and engaging the adults who have had multiple adverse childhood experiences, helping build coping mechanisms for them so we can turn that vicious cycle into a virtuous cycle, because the adults who are living with multiple ACEs are some of our biggest champions and leaders to actually help stop that transformation of ACEs from generation to generation. We need to invest in community capacity, and that's that collective impact model, because none of our agencies or organizations are able to do this on our own. We need to use the data, build support, and increase our community's capacity to really address trauma at the agency, system, and community level. And we really need to respect the wisdom of every person, their culture, their experience, their capabilities, and their aspirations. I've also provided a number of references that are on the slides, and we have an extra 9 minutes, and it's not an extra 9 minutes. I always leave to make sure I have a few moments at the end of the presentation if there are any last questions or comments. So at this point, I'm going to review the chat box, and Leanne, I'm going to invite you to take a look and read any other questions that might be in the Q&A.
Wonderful, and I do have 3 or 4 questions. I can, just wait and see if you address them, or I can bounce them to you when you're ready.
You can bounce them to me right now.
Okay, great. So one question came in and asked if you can comment on some of the research looking at epigenetic cross-generational effects of trauma.
Can you repeat the question?
Sure, it relates to epigenetics, and it says,
yeah.
Can you comment on some of the research looking at epigenetic cross-generational effects of trauma?
Yeah, that actually, it's funny, I just did a workshop on that. What I can do is, there is a lot of correlation. Now, epigenetics is really a field that is building in tandem with the ACEs. What I can do is I can provide some links to some resources that tie the epigenetics and the ACEs work, because there's a much broader answer to that question.
Thank you. And then we've got a comment and sort of a two-part question after the comment, and it begins like this. I would imagine that trauma would also affect in vitro if a pregnant woman experiences trauma. That's the comment. Can you elaborate on that? Question number one. What would be the modality of treatment possibly while pregnant and upon birth? Would that be what is called infant mental health?
So that is a really interesting question. I am not so I've done a lot of work and do a lot of work with neonatal abstinence syndrome. And we know that women who have experienced multiple ACEs have much higher likelihood of engaging in substance use while pregnant. So we see the obvious impacts on infants there, or the in vitro impacts there. I'm not aware of any studies, however, that are looking at the impact on an infant other than the impact of high-risk behaviors such as drug use during pregnancy. However, I'm sure that there is an impact. That's going to be one. It's a good question. I'm going to be doing some research on this one after the call, and I will find some resources on that, and I will add whatever websites or whatever information I find through my resources. I can't answer that question, but I find it really compelling.
Thank you. And then we have one or two more. Now more than ever, we are seeing more and more cases of behavioral issues among children and teens in schools and at homes. How do we know if the behavior is trauma-related or a lack of parenting?
Well, that's a really good question. Lack of parenting, I would have to unpack that. You know, it's interesting. If we look at lack of parenting, if we look at, we would then have to look at the reasons or the root causes first of all, how we define lack of parenting. Is it abandonment? Is it neglect? Is it incarceration? Is it poverty? Is it food insecurity? Because all of those behaviors that would be defined as lack of parenting are actually adult adverse behaviors and outcomes of their adverse childhood experiences. So I think that lack of parenting is really another way of saying adults that are impacted by multiple adverse childhood experiences. At least that's what this study would indicate. But going back to how do we identify whether it's lack of parenting or it's adverse childhood experiences, I would say lack of parenting is an adverse childhood experience. But looking at schools, and you're right, we're seeing the need for mental health services, for interventions, skyrocket across every public and private school system. Certainly, this is an area that I'm completely familiar with. Part of it is, first of all, naming and framing it. And that is looking at how to assess an early identification of screening. Because whether it's lack of parenting or another adverse childhood experience, the school is not going to be able to have meaningful impact outside the school building. However, if they can early identify those, whatever those issues are that are happening outside the school building, we can intervene earlier, working and focusing on developing coping and resiliency skills, so no matter what it is that they're experiencing in the community or in the home, that we're helping mitigate the impact of that. Now, that's not a satisfactory answer, which means that we really need to also be working with our organizations and agencies, after-school programs, hospitals, healthcare, so that we're providing a support not only to the children within school, but also in all of those other agencies and organizations and service providers that they come in contact with. But I also just want to land on lack of parenting means that there's something going on with the parent as well. And I often see that we blame parents, or there's blame assessed to parents because they're not parenting well. Well, what this ACE study is showing us is many times they haven't developed the skills that they need to, as we define it, quote unquote, parent well. And so we need to also make sure that we're working on developing those strengths and behaviors with those parents, understanding that they may have experienced adverse childhood experiences.
Thank you, Dorothy. And I've got one more question, and it came in relatively early in the presentation. And as you address this, I'm going to take control back of the presentation and get ready to have our closing technical remarks. And this question sort of relates to the overall study itself. And it says that she is wondering, this participant is wondering about, I guess, the concepts of correlation versus causation.
Yeah, the study, and there's more studies that are still happening now, the study really did identify correlation and not causal factors. And so what it really did, though, was it provided us with information that we hadn't had that tied in a more tangible way. Certainly more study is needed to identify causation in a tangible way. And if you look on the Center for Disease Control website, which is included in the presentation, you will see that there are additional studies that are working to establish causation.
Thank you, Dorothy. And Dorothy, if you're ready, I'm going to go ahead and bring us in for a landing. Is that all right?
That's great. And thank you, everyone, for spending 2 hours with me today.
And Dorothy, thank you as well. You know, we very much appreciate you taking time out of your schedule and sharing your expertise with us today on this topic. It's been very lively, and certainly we've gotten a lot of feedback from the participants. So as we wrap up, I do want to remind all of our participants, in case you joined us late, that when I conclude the webinar for today, your browser is going to bounce you over to the FATA website where you can log in or register and get access to the evaluation so that you can get credit for today's webinar. You will be prompted to register or sign in to complete the evaluation. And do remember, you can register with the site as a visitor at no cost. And then after you register, you will be directed onward to the evaluation. And I might just remind you that you should probably use the same email address when you register for webinars through our WebEx links and when you set up your profile in FATA system. And this just helps connect your attendance with your profile. However, I wanted to make you aware you will get a second opportunity to complete the evaluation through a follow-up email you'll receive later today in about 15, maybe 30 minutes. The sender will be Messenger at WebEx, so if it's not convenient to complete the evaluation right away, you can go back to your email a little later and complete it then. Do be aware that the evaluation does close at midnight on Tuesday, September 4th. And then, of course, after we verify attendance and completion of the evaluation, a statement of credit will be generated as a journal entry within your profile. And you'll be notified when a statement of credit has been generated on your behalf, and that notification is an email, and it'll come to you from info@FATA. And then as we wrap up, I did want to remind everyone that a copy of the PowerPoint presentation will be emailed to everyone within 5 business days. An archived recording of the presentation will also be posted on FATA's website within that same time frame. So you'll be able to share it with other interested parties that you think might benefit from it. So again, in closing, I want to thank everyone for participating in today's webinar, and of course would also like to recognize and thank especially the Florida Department of Children and Families, Office of Substance Abuse and Mental Health for funding today's education. So have a great rest of your day, and please hold now for the evaluation. Thank you.